Clinical case number 2. Very similar. 49-year-old male also presents with a complaint of grinding, and because of that habit, his tooth split, the first bicuspid, as you can see. He is also concerned with aesthetics, and he prefers to have treatment as quickly as possible. So, the restorative dentist, again, is ready to perform any procedure. So, with the insertion of the implant, I inserted it at 20 Newton centimeters and achieved an ISQ value of 52. So, what would you do in this clinical case scenario? Would you bury the implant and wait for osseointegration? Would you one-stage the implant by placing a healing abutment on it? Because 52 is still above that cutoff level, at least for me. And but keep the level of the abutment just below the gingival margin, so it's out of occlusion as much as possible. Place an immediate provisional crown on the implant and prevent occlusal contact by grinding down the occlusal surface, or remove the implant and let the socket heal before placing another implant. One stage by placing a healing abutment, but keep the level of the abutment just below the gingival margin. The majority of you have selected that. 43 says bury the implant and wait for osseointegration. 3% says place the immediate provisional crown on the implant and prevent occlusal contact. Okay? That's it for the voting? Good. I buried the implant. Because again, with a patient who is a grinder, a bruxer, who will pound the living daylights out of this implant, I don't want anything sticking through the gingival tissue, even though there's healthy tooth in front and a healthy tooth in back, because you will apply some forces on that healing abutment. And so I placed a cover screw on it, and I used my soft tissue augmentation procedures using a collar plug, a collagen-based material, along with LPRF to stimulate the soft tissue healing. And as you can see, within a week, week and a half, you can see how much that provisional has seeded into the soft tissues. And so you have to account for that type of force being placed on the implant. Therefore, it's not wise to put a healing abutment onto that unstable implant. So, at 52, how long would you wait now that you've buried that implant? Do you wait 2 months, 4 months, 6 months, or 8 months? Getting more and more difficult, isn't it? Based on the ISQ value of 52. Between 4 to 6 months. Well, I kind of give you the hint. There's 3 months. And now we get 57. So the question is, now what? It obviously is healing, but it isn't healing as rapidly as we would like or expect integration to occur, because 3 months in a normal situation, that should have been much more stable. But you see the value of successive measurements. It gives you a chronological log of what that implant is doing. And at this point, since you've exposed the implant, you may want to consider putting the healing abutment on. If you don't want to take a risk, put the cover screw back in. So it's very, very simple. So question number 3. With that ISQ now, how would you evaluate the implant at the next testing? Do you want to do a reverse torque test? You want to take a third ISQ measurement? Or do you want to assume integration has occurred and proceed with fabrication of the crown? Or assume osseointegration has occurred and proceed with the definitive restoration? And there's a reason why we're asking these questions, because it makes you think at what stage is that implant as far as integrating. And it makes you think, what do you want to perform next from a clinical perspective? Now, obviously, the implant hasn't really fully integrated at that point in time. And so do you want to put that implant at risk for failure by loading it? The obvious answer is no. So what we did was we waited longer. Now at 6 months, we take a third reading and we get 71. So now I feel pretty good about that, because 71 matches the cutoff value for Professor Boozer. And so the implant has integrated fully. Now this is not reverse torque testing. It's now tightening the permanent abutment or the definitive abutment so that you can go ahead with your definitive restoration, which you see here. So again, hopefully with this case scenario, you see what is running through my mind. And you see how I rely on the ISQ values to help me make that clinical decision. Should the patient wait, or should they proceed with restorations?